Hello and welcome to Healthcare Excellence Canada's Spotlight Series episode. I'm Andrea Piche, Senior Program Lead at HEC. My pronouns are she and her, and I am pleased to be your host today. Please note that this session is being recorded, and the recording will be shared with all event registrants. We are pleased to offer simultaneous interpretation of this event via Boost Events, a subsidiary of Boost Lingo. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of the screen. Now, if you don't see that interpretation menu, what you might see is a circle that has 3 dots in it and then the word more. If you select that menu, from there you'll be able to see the interpretation option. If you need support at any time during this webinar, you can reach out to our tech support. They are fabulous and you'll find them in our chat feature if you just look them up under tech support. We invite you to share your questions and comments at any point using our chat box in either English or French. And we encourage all of you to respond to comments and answer questions from each other in the chat as you wish. We have a large number of registrants for this webinar, and so I expect there could be a lot of questions, and we'll do our best to connect them with our speakers. However, we may not have enough time to reach all of them. As we gather today, I'd like to acknowledge that we are joined by folks spread far and wide from coast to coast to coast, as well as beyond, and that are on lands that have been walked by Indigenous people since the beginning. I'm personally joining from lands nestled between the Niagara Escarpment and Lake Ontario in the Niagara region of Ontario that are the traditional lands of the Anishinaabe, Ojibwe, Chippewa, and Haudenosaunee peoples and are covered by the Upper Canada Treaties. This is an area I'm learning more about with respect to the rich history and continuing traditions of First Nations people. It's an area where Indigenous people and European settlers have shared moments in the past of coexisting as equals. And I'm inspired by some of the stories that remind us how, through learning and unlearning, we can forge new paths of reconciliation and healing. I invite us all to continue to look for and act on these opportunities. And I also invite you to pop over into the chat and introduce yourself. Where's the land that you're joining from today? And if you're not sure, we've popped into the chat, or we will, the Native Land website where you can learn more about the territory that you're joining from. Today's episode is titled Shifting from Hospital Beds to Hospitable Communities, a catchphrase that we borrowed from Cormac Russell, one of our panelists today. This episode is intended to be a conversation about the role of community in creating and sustaining health and the need to shift services, resources, and power from institutions to communities in order to meet the health and social needs of everyone. One particular philosophy that encompasses this approach that will be discussed is asset-based community development, which we'll refer to as ABCD. And so with that, I am pleased to welcome our panelists. Come on into the room. Please turn your cameras on. Joining us today, we have Cormac Russell, who's the founding director of Nurture Development, Helen Lightfoot, a senior practice consultant with Alberta Health Services, Dr. Richard Lewanchuk, medical doctor and professor emeritus from the Department of Medicine at the University of Alberta, Donna Joanne Tapp, project director with the Cowichan Health and Care Plan from Island Health BC, and Lena Alsakran, evaluation consultant also with the Cowichan Health and Care Plan from Island Health BC. So welcome everybody. Nice to have you here. I am really looking forward to this conversation. And I think that we can just dive right in. It would be great if each of you could start with introducing yourselves, maybe just well, in whatever way feels good to you, and perhaps offer a little hint of the work that you're involved in as it relates to a community-oriented approach. And perhaps, Cormac, if it's okay with you, I would love to start with you and ask if you could do one additional job. And in addition to introducing yourself, could you just open us up with a little bit of a description of asset-based community development and that approach?
Happy to, Andrea. Thank you. And hello, everybody. Good to be with you in conversation. It's evening time here. You can see probably the darkness falling behind me, and I'm calling in from Dublin, Ireland. So for those who don't know me, Cormac Russell is my name, and I'm the founding director of a social enterprise that works worldwide. We have portfolios in 38 countries now. and it's called Nurture Development. And I'm also a faculty member of the ABCD, Asset-Based Community Development Institute, based at DePaul University in Chicago. So, Andrea, in terms of what ABCD is, really briefly, I think a good way of thinking about it is how it relates to other ways of trying to help or make change happen in the world. And I often think that there's four different ways that as helpers or as change makers, we can show up and try to make change or help change to happen. Not all of them are particularly good or bad, but they have different polarities. So one, I think, which probably feels quite impositional and top down is doing things to people. And I think at its worst, it's experienced as a form of violence. Um, but there can be occasions when it's necessary if it's done with free, prior informed consent. So then there's ways of doing things that I suppose are more charitable, more about trying to do things for people. But again, the danger or the shadow side of that is it can sometimes feel like it's undermining our authority, or we don't really have a sense. Where's my agency in this? I know you're doing something for me, but is it with me? Is it without me? Is it about me? Where do I play a leadership role? It's not clear. So those to and for are pretty much, I think, most people would try to stay away from them except as a last resort these days. And I think we've really moved forward into the space of trying to be more with and alongside the people that we serve in different ways. So we hear lots of words used to describe that with space, from co-production to co-design to co-creation. But again, what's interesting in my mind and in what I see happening in the world is a lot of the change making in the with space similarly places the professional in a key driver, key leadership role. Not always, but often. They have the final choice. So I think what's different about ABCD is it's not about doing things to people, for people, or even necessarily with people, but about creating the space where people can figure out what it is they want to do together with regular folks like them. So I think in that sense, thinking about the four different modalities of change, what's sort of significant around ABCD is it's very much putting the accent on people being leaders. So thinking about communities in the lead. So instead of thinking about bringing community or bringing health to the community, I think as a practitioner, if you're thinking through the lens of ABCD, you would be joining health in the community because you see the community as health creators. And that's in the by space. So to, for, with, and by. ABCD is really trying to orient to the by space. The final thing I'd say is almost if you think about this as a river of life metaphor, there are three swim lanes in how we do change. So a way of thinking about this is if you start in the first swim lane where you're thinking about what is it people can create from a health perspective by discovering, connecting, and mobilizing their resources within community. That's a lovely place to start because then it becomes much easier to figure out, well, what else could we as hospitals or as practitioners do with community that supplements those capabilities and extends them? That's the second lane of the swimming pool. And the final one is, of course, in health, there are things that populations need done for them. So starting with what is it people can do by themselves if we remove the barriers and we relocate equity. So there's equality. Then what is it we could do to help them a little bit without taking over? Then finally it becomes much easier to figure out what's left for the hospital to do that we must do for people in the name of health. So that's a quick overview.
That is a wonderful framing for this conversation. Thank you so much for that,
Thank you.
Cormac. That idea of right fittedness and the sort of alignment between who's holding what ball and who's doing what job, and how do we pause to look at who's best suited to do that in order to have the best outcomes in terms of health. So, thinking about asset-based community development, thinking about shifting from health being strictly, in the hands of institutions, but now looking a little bit more broadly to say, which pieces actually should be within hospitals or formal institutions, and which pieces are better serving folks when we're starting to stretch them out into other places and involving other people as primary decision makers. Thank you so much for that framing. And with that, I would love to bring in the introductions of all of our panelists. Perhaps Helen, could I invite you to come on and say hello and introduce yourself?
Thank you, Andrea, for sure. Helen Lightfoot here, and I'm based out of Edmonton, Alberta. I'm a co-lead on an initiative called Connecting People and Community for Living Well. And we're working with rural communities in Alberta to bring together the health, social, and community partners and those with lived experience to work collaboratively to build supports for people living with dementia and their carers, raising awareness within those communities around what is dementia, living well with dementia in that area. But really looking at, as Cormac was talking about that, how do we work with and how do we work by people in doing that work?
Welcome. Thanks so much, Helen. Um, Richard, can we come to you next for a hello?
Sure. Good afternoon, good morning, good evening to everyone. I'm Richard Lewanchuk. I'm just the recent past Senior Medical Director for Health System Integration for Alberta Health Services. But as we transition from one huge entity to four separate entities, our acute care group still is in existence, but our community group is just getting its feet under it. But we often like to explain health system integration as helping people be as healthy, well, and independent as they can be in their homes and communities. And we intend to continue on doing this work with the help of community or by facilitating communities.
Thank you so much for that and welcome. Can we move over to Donna? Would love to bring you in for an introduction.
Good morning from Vancouver Island, everyone. I'm Donna Joanne Tapp, and I work for Island Health as a director for the Cowichan Health and Care Plan. I just want to acknowledge today that I'm calling in from the unceded territory of the Cowichan tribes, which is one of 7 Indigenous communities in the Cowichan Valley, along with our Métis community and our House of Friendship. I've been a registered nurse for many years, I won't tell you how many, and have worked in Canada and in the UK, and have along the way picked up some experience and training in project management, lean methodology, and resource demand optimization. And right now I'm leading a large-scale multi-year community-focused project in the Cowichan Valley. And I'm just going to share a quick background on that because it'll help make the conversation make a bit more sense. So our Cowichan Valley is nestled in between Victoria and Nanaimo. We're home to about 100,000 people in the area living in rural and urban settings, small urban settings. And the area is served by a community hospital, which is actually at its end of life. And so we're really fortunate in that we are getting a brand new facility with an expanded bed base. But really early in the planning for that hospital, it was noted that the projected demand for services in that hospital was going to exceed what we had coming down the pathway for us. So our CEO, Kathy McNeil, made a decision that rather than lobbying for more beds for the hospital, that we would take a different approach and we would really look at community as being the solution. And so the health and care plan was born as that type of a project where we're really looking at a locality's needs. So it's very specific to our locality. In the planning, there was a lot of time spent hearing from the community itself as to what the needs were. And then what we're crafting is services to meet some of those highest care needs for or health needs in the community. But the way that we're doing it is by really walking in hand with our community partners, because we're a small area as healthcare. We can't do it all, and the community has so many good resources and abilities, and together we're actually being able to craft a much better set of options for people to maintain their health at home and to really drive their own health decisions. And we're gaining a great collective impact and some really interesting results through it. So we're really excited to be able to share that with you today.
Thank you so much, Donna. And thanks for opening up a little bit more of the specific context. I think folks are probably very interested in what are each of you folks doing that's different and that's more community oriented. So thanks for starting to open up that conversation into the very tangible pieces that you're working on. And with that, I'll bring in Lena as well to say hello and introduce yourself, and then if there's anything you wanted to share to build on Donna's introduction of the Cowichan Health and Care Plan.
Okay, hi everyone. My name is Lena Alsakran, and I am also calling in today from the unceded and traditional territories of the Cowichan people in the Cowichan Valley, where I have the privilege to work and play. I am a researcher and evaluation consultant working with the Cowichan Health and Care Plan at Island Health. And in my role, I am an embedded researcher. So I work alongside clinical leadership and point of care teams, and I support them with the translation of evidence into practice to fit local context and needs. And I also support them with providing real-time monitoring and evaluation so that we can guide decision-making through the use of data and program development. And as Donna previously mentioned, the Health and Care Plan is basically an asset-based roadmap to improve the health and care of a community and reduce the need for hospitalizations. And so we're applying the ABCD approach in a different setting, which is not community development, but community health development. So we're trying to shift the provision of care from the acute care setting to the community setting. And it really focuses on translating evidence into practice. But we know that we need to adapt it to fit the local context and need, because what works in one place may not work in another. And we're really trying to address the needs of this specific community. So as Donna mentioned, the locality, this is specific to the Cowichan area, and we're really trying to address their needs to impact acute care utilization.
Thanks so much, Lena. Maybe we can sort of dive a little bit deeper into some of the specifics of the work that's going on through the Health and Care Plan. Maybe you can share with folks sort of a little bit about the how. So you're talking about wanting to improve utilization of hospital resources. We know we have a bed crisis. We know that we're shifting services out into the community. We're knowing that you shared that we're doing that in a way that's specific to the makeup, the demographics, the needs, the assets of that community. But I wonder if you want to just paint that picture with a little bit of a finer brush and sort of help folks understand how did we go from, needing to reduce utilization and the demand for hospital beds to, pushing services into the community. And is it just about shifting them over? Are we just throwing them over to someone else to say, here, you do it? Or is the way in which you're transitioning them, specific, strategic, and what are the elements that are allowing it to take hold in the community? And what's some of the success that you're seeing as you're shifting services into the community?
Okay, sure. So I think it really started with identifying the need and why we needed to shift the provision of care from hospital to community. And that started with the Rebuild Hospital project. So they knew that the demand would exceed the existing resources, and they wanted to dive in deeper to figure out why that was happening. So it started by looking at who was coming into the hospital and identifying the people that could be supported in community. So we looked at the highest users of acute care services and who could be supported in community. And they did that because they made the assumption that people that were coming there were basically not getting their basic needs from community, and that these are the folks that we need to be focusing on in community. The next step was really going to community and engaging community and everyone in the community setting. So this was a large scale project, and the engagement went over a span of 18 months. So they connected with expert panels, community organizations, volunteer organizations, the Indigenous community, and the physicians as well. And they really wanted to hear about what these folks were going through and what they needed and what the existing resources were. So it was an asset-based approach. They looked at what resources they had initially and at what they could add to it to expand on it and improve the health and care of the community. And that's how it really started. And that was before COVID. And then after COVID, Donna, the project director, led the project and started implementing and operationalizing the project. So that's where it all started. And yeah, and could you just remind me what the second portion of the question was? Some of the impact and what we introduced, and was that the second part of the question?
Yeah, just what are you seeing based on working differently? What's happening in your program as a result of not just moving the services, but the way in which you're partnering with communities, the way in which you're gauging your communities? You know, what are you seeing? What's happening, and how is it impacting the people in the community?
Well, we're seeing a lot of impact. And I think one of the biggest impact is the partnerships that it's creating and how we're leveraging resources and how we're able to do so much with so little. So the amount of resources that were implemented in this plan were not a lot compared to the impact that we're seeing. So historically, the hospital was in a state of over occupancy. And I think this is something that a lot of people can relate to right now. And now the hospital is at under capacity, and it is doing great. And we are seeing people getting better care. People are healthier in the community, and they're not needing to go to the hospital. So they're not trying to shift people out of the hospital. They're trying to make them healthier in their communities and not need to go to the hospital. And we're doing that by implementing care models that we know have the ability to reduce the need for hospitalization. So we're taking we're taking these evidence-based care models that we know have the ability to do that, and we are translating evidence into practice. We are adapting to fit local context and need, because we know that the needs of this community might be different from the needs of another community, as well as the resources and the policies in place. So there have been a lot of adaptations that needed to take place to make these models work. And we're really seeing that shift in the community. And we're seeing a reduction in acute care utilization. So for the priority populations that we have supported in community, we're seeing a huge reduction in the use of hospital bed days. And it's really exciting to see. And I know when we first started to see a shift in hospital bed use, it was so exciting. It's like, oh my gosh, this is working. And then the impact was sustained, and it's been 2 years since. And everyone is just so happy and excited. And we're just really excited to share this because it's amazing. And yeah. Donna, would you like to add anything? I know Donna probably has a lot to add because like this is her project.
I always have lots to say. I would just add to that when you look at what we've done in Health and Care Plan on the exterior, it looks very similar to what a lot of people are doing, because some of the highest user groups coming through the hospital that can be supported in the community are some of those chronic disease groups that we see across the board, like COPD and extra resources for palliative care, those kinds of things. But I think the difference that the thing that's making the difference is the how. So if we go back to the thought around this being like a really community informed and driven process, we've really made an effort in the implementation of this to create closer bonds with our community partners and really strengthen the network of care, so that as people have to wake their way through the system, that it's easier for them to navigate and get what they need. So right place, right care, right time. But also because we have our community right with us, like they've been with us all the way as we've done our project planning. So for every new service we've put in, we've had them at the table. We've been listening to what they can provide us for lived experience. And they're also letting us know that, we can do this in the community. We have these resources. This would be really good for these people if you want to help connect them. And so we're kind of just working together that way to bring this wraparound care to people. And because of that, people are able to do more for themselves in the community. If you connect them to the resources that are there, they will use them. And we've really seen that with our community groups. They've been feeding back to us, like, since you started, our referral rate has just grown exponentially. Like, this is a good problem, but now we've got so much work to do. We've got so many people coming to us. So, that piece is working too. So just working together and being able to tackle the same issue from different perspectives in different ways with different supports is just giving that impact that's really starting to show up in our results. So thanks.
Thank you, Donna. And the notion of engagement, right? From I don't want to just say patient partner engagement, but just community member engagement at another level, at a more intentional level, I think is what I'm hearing a lot about. And that question came up in the chat around where are the patient partners here? And what I'm hearing you say is they're everywhere. They're in everything that we're doing, which is fantastic. I have a feeling Helen, uh, might have some thoughts to layer onto this. I don't want to put you on the spot, and I welcome comments from any of the other panelists on what's been shared so far. But since you've turned your microphone on here, come on in, Helen. I'd love to hear about what's resonating for you from this experience and your own experience in terms of instead of shifting things into the community, starting things within the community.
Yeah, exactly. No, I think lots of those the elements that Donna and Lena are talking about are what we're seeing when we're bringing those different partners together. And again, part of that partnership are community members as well as people with lived experience. And it's through building those relationships that are just key. You have to build the trust. The work moves forward at the rate of that trust building. But then people start to be able to be more open around, well, actually, we have this resource we can bring to it. We have this knowledge we can bring to it. It's important for me to contribute in this way. So finding purpose for people also in doing that work. And it's just amazing when you start. Our work started during the pandemic, and so there was a lot of Zoom meetings and bringing people together that way. But as that trust built, all of a sudden, just the growth and what was available to people for support groups, for memory cafes, for education events, gardening, virtual events, it just grew and grew and grew. And again, like Donna and Lena, we saw great return on investment for the hospital. The usage went down within the 5 communities within our first grant, but also the social return on investment showed good returns as well. So it was impacting and helping all the different service providers, as well as the people living with dementia and caregivers within their communities. So just really that key fundamental about building those relationships and building the connections. And I think when you have that in place, then those communities are ready to embrace these types of initiatives and supports that are coming because they've got their basis built there.
Something that you've just brought to my awareness in this conversation is the notion of not always knowing where you're going when you start, right? So I think for a lot of folks, when we talk about we want evidence-based solutions and we want, research-oriented solutions, yes, we do. We want to take all the best practices and squeeze out all the juice of what you've learned and what Donna's learned and Cormac and Richard. But I think there's a need, or you have to a certain comfort with the unknown, the idea that if you are helping people create by themselves or with them, you can't know,
No.
where this is going to go. Come on in.
Yeah, I was going to say it drove our evaluation team crazy because they kept saying, what are you implementing? What will you be implementing? And we said, we don't know. We don't know yet. They need to come together. They need to have the conversations. They need to do some imagining and creating. And over 18 months, they got there. They were implementing, at that point of it. But being comfortable in that gray area, I mean, it's how you help people themselves get into that leading position. Because if we told them what was going to happen, we would then be leading. At that point. And that's what we were trying not to do. We were trying to have them come together, build those collaborative relationships and set priorities together and take on that leadership role with it. And again, that takes time to do it. But I think, some of the things we were looking at was the connections. What was the depth of the connections? How many connections? It became a model that developed kind of within there was what we call a hub and spoke around navigation for individuals within those communities. There was a kind of a close working group, and then they had many connections out in the community. And so if an individual was looking for help or resources, if they touched anybody within that network, then they quickly got connected with the service or support that would meet their need. But it was through that development of relationships that really kind of organically grew, and we saw this across all the communities with it. So it again, we couldn't say, okay, implement a hub and spoke model, because we didn't know it existed until they created it. And so it is that being really open to where is this taking us? That seems to be meeting a need. And again, it's part of our role was checking in. Is this meeting the need? Is it helping people get what they see as priorities with it? And that voice of lived experience was just key within that. Okay, is this helping? Are you feeling like you have input into it? So just keep coming back around and circling back around to that.
Yeah, that's really resonating, and I'm seeing a lot of what you're sharing is resonating with our audience through the chat as well. Richard, I'm curious about your thoughts on this from the perspective of health system leadership.
Sure, I think Cowichan has made two really good points. The first one is that they've demonstrated a total change in mindset and a way of approaching things. So they're not doing the same thing in a different way and hoping for different outcomes, where we heard that before. And so it reminds me a little bit of Singapore. And Singapore has been saying this for the last 20 years. So they would say that really hospitals are monuments to failure, because when someone's admitted to hospital in Singapore, the first thing they do is they slap their foreheads and so they say, oh my goodness, we have failed this person. And then the next thing they say is, what could we have done to have prevented this hospitalization? So they're thinking exactly as Cowichan has said, in the community, how do we keep people healthy? We've been taught, and so the second point is we've been taught, our mindset is about the illness care system. And I can tell you in Alberta, we spend 89% of our healthcare dollars fixing broken things. So in illness care, and only 11% in wellness care or health care. In some systems, it's as high as 96% of some health systems' budgets are spent on illness care. There's an interesting study done in the United States about cars, automobiles, and they found that 60% of our expenditures on cars are related to prevention and only 40% on repair. So I actually went down the street to our car dealership and I asked the service manager if he could pull his records, and he got exactly the same numbers, like to the same percentage. 60% of their services were preventative, 40% reparative. What's wrong with this picture? So I think shifting that mindset from illness care, and I don't mean to make demean initiatives such as hospital at home types of initiatives, where again it's illness care in the community, but really shifting that focus to how can we keep people healthy. That really is our goal, and I think they really demonstrate this nicely in that thinking in Cowichan.
I would agree. Cormac, did you want to share any reflections on what's been shared so far? I know you were really close to a lot of the work that's been happening in Singapore, and probably have some great examples there.
Yeah, absolutely. It's lovely, I think, to just listen to people describing their practice. And I think the more we can reflect on our own practice, probably the more that we'll see there are elements of foregrounding community and community health creation in all kinds of things that are happening. And I'm sure there's many examples that people listening in could bring to the conversation as well. I would agree with Richard that there's something interesting and promising in what's happening in Singapore. And just for context, I think it's helpful to take a zoomed out and then narrowed in approach to this. So at a very wide level, in Singapore, there's two things that at a policy level, if you like, I think they do, which are very useful in this conversation. The first is that they're thinking very much about what they're trying to get beyond and what they're trying to move beyond and towards. So they have this very broad idea at national level of what they call three beyonds. So the first is beyond healthcare to health. So they're making a distinction between the machinery of healthcare, the hard and often very expensive stuff that Richard was talking about, spending 89% of your budget on, at the acute end of the system, where it's very costly, it's often too late, and it's very hard to step people down and back into community, particularly when we don't spend a lot of money animating community health creation anyway. So it's a really interesting one, because the system is so focused on the entrance that even trying to convince them that the exit and getting out of the exit of the hospital and going upstream is a good idea becomes really hard to do because it's crisis oriented. So I really like that idea of getting beyond healthcare into health. What does it mean? Obviously, it's not just the absence of illness. And I think that's what I've been hearing really being lifted up in the conversation so far. We're not just trying to focus on illness. And that's part of the prevention idiom as well. A lot of the prevention idiom is still stuck on trying to prevent illness. What we're hearing here today are stories of how we're precipitating health creation in the community. So this isn't an attempt to stop the filling of hospital beds. It's the attempt to stop institutionalizing people and instead animating and supporting them to create solutions that are better for them and their communities close to home. So, it's not about saving hospitals money, it's about saving people from being institutionalized. How do you do that? Well, you do that by creating community alternatives. You deinstitutionalize by recommunalizing. And this is a big challenge. So the second beyond is beyond hospitals to communities. So this isn't about foisting responsibility onto communities because we're running out of money and the platform is burning. No, it's about recognizing that for a long time, our model was expropriating capabilities in communities and pulling it into hospitals inadvertently. It was just the system was, you'll be better because we know better. So the key actor was the doctor, the arena of change and health was the hospital. I think what they're saying in Singapore is, to Richard's point, that's not right. That's from a pathogenic perspective, it's totally right. So through the lens of sickness, yes. But through the lens of health and salutogenesis, no, no, and no. So this is an ethical rather than, an economic choice. And moving further upstream seems to me to be also, I think, an equity-based choice, where you're actually recognizing this is about relocating equity as well as authority. So in many respects, the third piece is beyond quality to value and really beginning to see how do we move beyond quality improvement and measuring success by the quality of our programs and really moving into value and valuing quality of life. So measuring our success by the extent to which people are living more interdependent, healthier lives. And one of the things that's interesting in the Singapore story is if you really drill down to practical examples, I think one of the best examples is a hospital in Yishun, where they've really begun to think about, well, how do we make this real? And so many of the staff who would traditionally have been located in the hospitals have now been decentralized out of hospitals, and they're working in local neighborhoods where most of the referrals are coming from. And they're living the life of the local. So as well as decentralizing staff, getting them out of the hospital and into the local, so in this sense, they're making the neighborhood the primary unit of health, not the hospital. Now we're in a new arena, and they're saying the key actors are not the doctors or the nurses or the allied health professionals. The key actors in health creation are not practitioners, they're not clinicians. They patch people up. By the time you get to them, it's too late. The key actors are upstream. They're your neighbors. They're your associations. They're the local institutions. It's the Bertsorg. It's the primary care teams. It's the hospice that actually gets, it's not about waiting till people come up the hill to die, but are releasing their staff to go down the hill and live the life of the local. Well, that's what they're doing in Yishun Hospital. They're decanting, getting people out, and they're saying to their staff, you've got to democratize the way you think about health. So don't do health to people or for people. You get with people and find out what they want to do. Most of what people do to be healthy, they're doing while not thinking, I'm doing this to be healthy. They're living. They're living the life of the local. The sad reality is in many of these communities and many of these neighborhoods, for very young people and particularly very old people in Singapore, they're actually very isolated. They're very, very disconnected. They're not sharing their gifts. They don't feel they matter. And that is a very big precipitant to very poor outcomes. And so a big part of what these decanted staff are doing is almost taking on a community animating role and inviting people to come back in and reconnect with each other and do the things they care about. So if somebody wants to set up a group and there's a barrier to doing that, the job of the staff is to work with the local community to remove that barrier, to cheer them on. Maybe it's about finding some funding or a venue, but not doing for the community what the community can do for themselves. Why? Because a key determinant of health is our autonomy and our power. The more we have a sense of collective agency, the better we feel, the better our outcomes. So politics matters here. It isn't just about the social determinants of health, but it's the social and political determinants of health. So what the staff are beginning to recognize here is the more people have agency and collective associational life, the better the outcomes are across population health. And they're learning to stop thinking about neighborhoods and populations as pools of potential patients. And they're beginning to see them as agents of health creation, waiting to be discovered, connected, and mobilized. One of the big lessons that they had to learn, because most of them are empaths, is to stop rescuing people. You know, it's a misuse of our power clinically to solve problems that don't belong to us. I remember somebody in a hospice in Scotland once saying to me that, you know, the folks we look after die twice, first socially and then biologically. We do hardly anything about the first. And I thought that was a great insight. So I think what I'm describing to you here is people learning to do more about the first, the social piece. And a big piece on that was, as an empath, to learn to lead by stepping back. So when you support people that are disconnected or have agoraphobia or maybe are shy or whatever it might be, you've got to figure out, not when you leave or abandon, but when you step back and you allow those new relationships to flourish on their own terms. So, you know, it really asks questions about, for example, why so many district nurses are facilitating breastfeeding groups. Why would breastfeeding moms not be facilitating those groups? You know, and in the same way, really asking, are we taking on roles and functions that don't belong to us, that actually belong to communities? Now, one of the things we know is that authority to lead in your own community is something that's hard to, you know, just step up one day and assume. So we need to do the community building work that creates those on-ramps. And I think, again, this is something we're hearing in the examples that are being described. The final thing I'd say is an issue, and one of the things I value most, and I think we're hearing this as well, is there, you know, in a forest you have a canopy, and it's known in biology as an overstory. And I think in medicine and in health, we have an overstory. And the overstory is our health is determined by doctors and clinicians and allied health professionals, and the arena of health creation is the hospital. I think what I love about Yishun and what I love about these stories is it's challenging that story. And it's introducing a new story, which says, yes, hospitals matter, clinicians matter, all of that stuff is hugely important, but it's supplementary to the health creating capacities of community. And here's the thing, in Yishun and in the examples we're hearing here today, I think what we're reminding people is that actually your health is very contingent on the extent to which you're living in a connected community. And so part of health creation and being a health practitioner, if we're not going to do any harm, is let's not do harm to that. And maybe on a good day, let's try and do some good. So I think that's what we're hearing, and that's what we see not everywhere in Singapore. We should be careful, I think, of best practice, because best practice is often the enemy of better practice. But I would describe it as promising practice. And I think we're hearing promising practice here today as well.
Absolutely. Absolutely. There's rich examples. And in the chat, if you've been looking, there's a lot of folks that are sharing their experiences. Um, you know, and I just want to acknowledge that there's a lot of great work aligning with this. You know, a lot of folks are pointing to the great things happening in public health and questions around public health. I think, out of your sharing, Cormac, what's really resonating was that notion of people dying twice. I saw that come into the chat, first time socially, the second time clinically. And I think that was an aha moment for a lot of folks. Before I throw another question into the mix, I'm just going to open up space again. Is there any comments or reflections from across the panel on the sharing that anyone wanted to build on or share an example of or add some emphasis to?
Yeah, so I really wanted to add something to that. And I love how Cormac really related to the impact of agency. So the Cowichan Health and Care Plan was conceptualized by Island Health, but it was handed off to the local clinical leadership to implement and develop and operationalize. So the local clinical leadership are, as I see them, are an extension of the community. So they wear two hats. They live here in the area and they're also healthcare providers. So they really are invested to seeing this program succeed. And for them, like, failure is not really an option because this is their home. They're going to be users of the healthcare system. If it's not them, it's going to be their family members, their neighbors, their friends. So when I see them engage and when I see them working with community, there is that common language. They go to the same schools, they go to the same grocery shop, the rec center. They see each other on the weekend. So that really helped develop the partnerships and really helped really develop that network of care that we're seeing. So we have community members, community organizations, as well as local leadership working on different things, but they all have that shared goal, which is improving the health of this community, allowing people to age in place and keeping them out of the hospital. But doing so by keeping them healthier. So clinical leadership here really they are just community members. They are part of that local community. And that was really helpful because they had the existing knowledge of how things work in the community, what might work, what might not work, how to implement new strategies within the local structure, how to integrate things, and then who to connect with. So they were able to identify key partners who needed to be available, who needed to be on the table to make those decisions and get that in place so we could achieve the impact that we did. And when I started with Donna, and she can probably um, just add a few things to this. She said that I am a project team of one, but I have many, many, many friends. And at the time when I first started, I didn't understand that. But the last couple of years working here with the Cowichan Valley, I've really started to see how important it is to create those partnerships for leading healthcare and for leading change. So, Donna, would you like to add anything to that?
Oh, I have so many things to add to that. Yeah, on the leadership perspective, just want to sort of backtrack and just talk about like the senior leadership piece of this too. Like senior leadership has really given us a lot of latitude to take this work and to make it specific to Cowichan, and they've given us the space and the trust to do that. Not that doesn't always happen. So, that is a big factor in how we've been able to roll this out, and so appreciative for that. But then also just thinking about like the patient perspective, when you look at literature, everywhere you look, it's people are saying like, I want to be cared for in my home. I want to be as healthy as I can. I don't want to have to go to facility. And so we're really trying to keep that, in our hearts as we move forward and we do this work. I always think about, what if this was my mom that was getting this care? What would we want? And, if it was me, wouldn't I want to be able to do these things for myself and not rely on everybody all the time, or the healthcare system all the time? So we're really trying to build those connections and give those options to people so that if they choose to, they can go that route. And then the other thing that I think is sort of pertinent to the conversation is the fact that for both the Alberta team and ourselves here, we implemented our projects in the middle of COVID at a time where social isolation prevailed. And for a lot of us, the community resources collapsed for a period of time. And we're coming out of this, and we've got this social isolation piece to tackle, and communities trying to build up their resources again. So again, working alongside with them and working in tandem and supporting each other to get everything back up and running and to tackle some of these issues together is just really, really important, because healthcare can't do that on their own. So I just wanted to sort of add those pieces in as well. I don't know, Helen, what was your experience there?
Yeah. Yeah, no, I think absolutely reflective of the comments that you've made there, Donna. A couple of things that just came to my mind as you were talking was um, because we are Health Canada grant funded, so we had some independence in the work that we've been doing. And so I think, as you were saying, that support from the senior leadership to give that freedom, that's also the position that we have found ourselves in with it, and it's made all the difference, because then we're really led by what we're hearing from the communities at that community level with it. I think part of the piece about being able to take this further is needing that, I guess, unlearning to happen at some of that system level of it's okay to not know exactly what is going to be implemented, that the way that the solutions will be found is by people coming together and developing them themselves. And that's a very different turn. We have deliberately moved towards a basis of well-being for our work, moving away from kind of that medical model. So we aren't doing the what is the problem and how are we going to fix the problem, but how are we going to build the well-being together with people. So I think there's some real work there around how do we change, how do we learn new ways of doing that work and partnering. The other thing that, as you were talking about partnerships, that we're seeing is the teams that we've worked with probably now, some of them at the very beginnings of the work, probably 6 or 7 years, is that development of that really local deep network that they have, but also the development of networks that we've been able to connect them with provincially within the healthcare system, but then also across community-based senior serving organizations. And I know we've learned a lot in Alberta from BC around Healthy Aging Alberta and from Healthy Aging BC, and building that kind of infrastructure that is there to tap into, to share information, and to build those supports within the community too. So I think as both those things have come together, it's the relationships locally, in between, and as a structure that are needed to be developed and in place for it to be sustained and to continue forward.
Helen,
And
you've
that,
just pointed to something. Sorry, I'm just going to just point you to the chat as well,
Okay.
and then bring in some other folks on this. But this notion of trust and the speed at which community development work happens, right? This is different than just implementing a project.
Yeah.
This is our aim statement. This is what we're implementing. This is what we're measuring. Go.
Yeah.
That this work happens at a different pace, and
Yeah.
that speed is really dictated by the rate at which trust goes. And how do we hold that space so that we can bring communities into trusting relationships with themselves and each other and community members, but then also in the notion, somebody had popped this into the chat, is, how do we ensure that our health system and our health providers build trusting relationships with community, that they know, what, the community's got this. I can step back. I don't have to be, doing for, because I know the community will hold this person up, these community members up. Any thoughts on that?
Yeah, I mean, it absolutely does take time. I think the thing is, I'm not sure it takes more time than the ways that we've done it, because we implement a project, we see some success some places, and then it doesn't work other places because it doesn't have that trust built into it. And so then we start again. So if we run a project or program 4 or 5 times, that's let's say that's a year. But if in an year you've built the trust, you've taken maybe 3 or 4 months to really bring that together, bring together the ideas, and then you have 9 months to implement and grow that, you're often further ahead at that year time, because you've slowed down and built that trust at the beginning of it. So our own experience is it doesn't take longer in the long run, and often in the long run you're where you want to be, as opposed to kind of starting again with a new approach with it. But yeah, it is holding that space for teams to come together, people to come together, to be able to share what they know, to really learn about the knowledge that everybody has. I was thinking as Cormac was speaking, is that there is a ton of knowledge within the community around health. We just haven't called it that before. And especially when we recognize the social connections that people have and the huge impact that that has in people's lives, that is the foundation of health and being able to create that health. And so I think different systems have been so focused internally that they've kind of not had the time or ability to look and make those connections. As well as I think there's some big myths that we all live within. And one of them is that you're safest within a facility, or that as you have more maybe physical needs, that's where you need to end up being. But we know that that's not where people are. If you just look at the population, the vast majority are in the community being supported by caregivers often. And there's another group that needs that support from their communities. That is where people are. And so we've had this model of you move towards facilities as you need more help, but that actually isn't what is happening. It is actually happening within the community. So just raising that awareness that is actually what is in place. I don't know if that answered the question, Andrea, or not, but those are my thoughts from the last discussions.
Those are great reflections. Great reflections.
Sure. Could I add in, Andrea, as well, is sort of two components to that. I think the people in Cowichan have shown really great courage in what they're doing. You know, Trust 101 would say, well, trust is built as a result or occurs as a result of relationships, and we often don't, allow those relationships to develop. We're so focused on transactions that we forget that second part. But the other thing is that it sort of relates to this power dynamic, and it's sort of very insidious, such that, we in the healthcare system have this, thought that we think we know what's good for people. Well, how on earth do I know what's good for you or good for a community? Only the person or the community can determine that. And so it's very, very challenging and uncomfortable for us in the healthcare system, to relinquish that imaginary power, I would say, so to speak. We often use the term, in order to gain power, you have to give up power. What we really mean is, in order to get the collective impact, the collective power, we have to give up this individual power. And just because we operate in the space where we're talking about relationships versus transactions, always have to use the stories. So there's a community in northern Alberta where we looked at their so-called health, and there's too much smoking and too much drinking and too little exercise. And so the community was told, you gotta, pull your, get with the program. You've got to decrease the smoking rate, and you've got to, exercise more, and you got to eat healthier and drink less, and so on. And the community told us to go jump in a lake. And they said, what we want is we want a swimming pool. I said, why on earth do you want a swimming pool? That's what we want. That's what's important to us. So the town itself organized a committee. They collected money. They got contributions in kind. They built themselves a swimming pool. And lo and behold, what happened? They had a place where in cold, wintry northern Alberta, people could gather, families could gather. Older people could do aquasize. There was activities for the children, and the public health benefit of the swimming pool probably far exceeded anything that a stop smoking poster would have done. So again, but it was challenging to be able to give up that power. But it's also liberating as well when saying, we don't have to be in charge. We can be there to help. We can provide our technical expertise, our knowledge. But the people really know what's best for them.
That is a fantastic example. I love that as a really clear illustration of the relocation of power and authority. That is animating the buy space. We want this. This is what we know we need for our health. And this is where the role of the institutions and the organizations is to say, okay, we'll help you make that happen, as opposed to, and we're going to do this for you, and we're going to do this our way. So that is a great one to add to all of our collective repertoires. We're trying to really, communicate across our system the need for community development. Love that. Cormac, yeah, I thought you saw you come off your microphone. Come on in.
I was just thinking there, building on what Helen and Richard is saying, and just an eye to the chat as well. There's great conviviality in the chat room as well, of people building and sharing stories and examples. What I love about this is we're talking at two levels. One is sharing the stories, and the other is at that kind of meta level of drawing out principles and saying, look, here's why we do what we do, or indeed why we're no longer doing what we used to do. I mean, because there are clear shifts, and in a sense, some of what we're talking about here is what not to do to be helpful. So I just want to share a story about the interface, because you rightly directed us at the beginning in this conversation to say, I want you to think about right fittedness and a question of alignment. And I think that's a great arc. That's the golden thread running throughout, and want to keep coming back to. So let me just tell you a brief story about where I think alignment was discovered to be the issue and where people started making change happen. And it's in Austin, in Chicago, a neighborhood in Chicago. And in the 80s, a lot of folks in, Austin and Garfield Park and North Lawndale were really, really cross because the hospital that was local to those communities, they felt wasn't serving their communities very well. Um, People of color were not on the boards. They didn't feel that they were representative in the staff, and they didn't feel the service that they were getting was meeting their needs, their population health needs as a community. So a very progressive leader in the hospital said, we need to enter into a conversation with the communities to better understand what the issues are here. And what became clear was that it wasn't just about service provision. So it wasn't a conversation between service providers and potential patients or service users. It was a conversation between caring civic practitioners, many of whom lived in the community, and citizens who lived in the community, who were trying to figure out how to align better to make sure everybody was well and healthy. And that, kind of culminated in one particular area of curiosity. So one person at one of the public meetings stood up and said, why are so many of our young boys, our teenagers, ending up in A&E every weekend? It would be really helpful to understand this. Now, long story short, when they actually looked at what was happening, it was rather humorous in the initial stages. So they came back to the community and told them what their teenagers were presenting with when they came into the hospital, but they used the wrong languages. So they were talking in Latin and Greek, literally, actually. And the community said, well, could you just actually tell us that in plain English? And so they translated, all the kind of fancy terminology into a description of what most of the boys were presenting with, which were anything from, bruises related to domestic violence in some cases, to dog biting. Dog biting actually was one of the highest reasons why young men were presenting in the hospital in the 80s. The other was actually a particular injury around the pelvic region, and it ultimately came out that the dog biting was as a result of the kids breeding dogs. I mean, quite, not very pleasant to look at and very vicious dogs, and fighting them at the weekends. And the reason there was so many pelvic injuries was because trucks were using the neighborhoods as a cut through to avoid, highway traffic. And kids were jumping on the back, and the drivers would accelerate. They would fall off and hurt themselves. So one person, the community leader, stood up and said, they're not medical issues, they're community issues. Now, our kids are going to you when in fact what we need is an investment in community development so we can begin to address these issues in the community. In the absence of that, of course they're going to go to you. But that's, they're going with social problems to a medical facility that's going to fail. And then we're getting angry with you because we don't think you're serving us. And so that conversation precipitated, I think, a beautiful example of community health creation, which is in Austin. And it's an example which I think to this day, 30 years on, is worth visiting if people have time. and it's called Every Block a Village. So in a very urban context, they have recognized we don't have a youth problem. We don't necessarily have a health service problem or a health care problem. We have a village problem. And they're using community development to respond to that. They also have a poverty problem. They also have a structural racism problem. So beginning to get to the root issues rather than just patching up the symptoms when it's too late, I think is absolutely key to this conversation.
Cormac, I would imagine that, in response to the illumination of where the root of those challenges lie, that folks stepped up, that they said yes, that they went to work on those issues gladly, in lieu of, the healthcare system issues. And I'm hearing that in other stories as well, where, in the sharing so far today, what I'm hearing that's consistent is that when people ask community to participate, the community says yes. And I think there's a bit of a myth that, that people aren't going to want to help, that people aren't going to want to do the work, that they just want to be served. And I think that is a myth. Excuse me. I think that people want to be asked. They want to be
Yes.
asked to contribute. They want to be
Yes.
asked, what the needs are. They want to be asked to offer their gifts. They just aren't going to volunteer them without knowing where they could be used. And so I would love to
Absolutely.
hear, the experiences of folks on this panel about what happens when you asked. Our friends here in Cowichan, when you went to community and to people you hadn't worked with before, what were their responses?
So it's always positive. If you ask for help, somebody will come and provide you help. And I think that we've really experienced this all along the way as we've developed our services to sort of meet some of the care needs that are out there. When we've been designing our services, we've always started with an evidence-based model that says, if you do this stuff, then people can stay at home and be healthier. So that's our starting point. But when you bring the community to the table, so when you bring a patient partner to the table, when you bring the volunteer coordinator for the area to the table, when you bring a local physician to the table, and you start to talk about this model of care that you're looking at, they'll start to tell you what does and what doesn't work. Or even, you shouldn't really say things this way. You should frame it in this way. And have you thought about this? And have you thought about that? Like, they bring so much to the table. And what's happened for us is that we have not ended up with the same model that we thought we were going to implement. We have adapted that. We've taken that information on board. And I think we've created a better product that's more applicable to the people that are using the services at the end, because their voice is part of that. And just going back and reflecting on what Helen was talking about around trust, like when you bring people to the table, and they get to share that, and then you craft something together that makes sense for everybody, that actually brings the trust to the table. And so then the next time we're working on a different piece of work and you bring those people back, you've got a new level of trust, and it's just a whole different dynamic. And so it builds, and then they go out and they talk to their partners in the community about what's going on. And it's been a really positive process, really, for that. And that's sort of when I talk about that network of care that we're building, that's sort of what I'm referring to. Like, we have those relationships already, but we're building them up, and it's just improving everything that we're doing as we go along. So, I really resonated with, Helen and Richard, what you're talking about in that realm of trust and development. So really appreciate you sharing that. Thanks.
I was just going to add to that there, in every community, things have been happening. So we're making an assumption that there's nothing and we're coming in and starting something new. But in every community, we've built on what people have and what the connections are there. I think some of the work has been around, okay, so how do we now figure out what the priority is going to be? How do we develop shared decision-making ways that we're going to be in, and how do we actually put our money on the table and share our resources, which can be time, money, effort. So, those kinds of things also. But it's happening in the community. It is finding out what is happening and starting from those very kind of beginnings part of it. And there was a question in the chat around communities that maybe are having more difficulty, having more conflict. There there is still something positive happening in those communities to tap into those people who are already trying to elevate the work that they're doing and support them to move it forward. And again, so that trust building might take longer, because if there's conflict, then that trust may have been really undermined. But there are positive things happening in the community. I think we always have to be looking for that.
Well, and I think welcoming the conflict. I mean, I think the conflict is important and it's powerful and it's a useful pointer, right, to where we need to get to work and where communities may not have been engaged that need to be engaged with. Like, I think it's actually a really important piece of community development is understanding that conflict and leaning into it as opposed to waiting for it to resolve before we can do something. I think the conflict is the starting point for so much really important work. Come on in, Lena.
Yeah, so I just wanted to add a little bit to that. So, in our experience, when working with community partners or working with volunteer agencies, we got an amazing response. So here in the Cowichan Valley, we have the Our Cowichan Community Health Network, and they're just a huge range of organizations that are able to contribute to many, many, many things. And the amazing thing of collaborating with them and working alongside with them is that they're able to address things that healthcare can't address. So healthcare can provide healthcare services, but we know that there is so much more that impacts health outcomes other than healthcare services. So let's say transportation, housing, food security, and they're able to have a huge impact on those things. And so we're able to work by working together, we're addressing healthcare needs and social needs, and that's why we're getting that huge collective impact that is showing up in our hospital occupancy. So they always welcome collaboration, and they are and they really show up. I mean, we've just implemented a falls strategy, and what we want to do is we want to highlight the impact of falls in the area. And we knew that without community, we wouldn't be able to have the same reach and the same impact. And uh, by asking community to lead this endeavor and this project, we knew that it would be much more impactful than if we were doing it alone. And so we work together, and I think that is really part of what everyone calls the secret sauce in Cowichan, is that community has played such a big role, and they really lead a lot of things here.
Wonderful. Wonderful. Cormac, I see your hand up too. Come on in.
Yeah, I'm just wondering, again, following and trying to track some of the conversations. And so there's a couple of themes emerging in the chat. One is some people are saying, well, this is all well and good, but it doesn't relate to my context. So I hear that and I want to pick that up. The other is questioning, and it's great, I think, to bring these dilemmas and doubts in. So we welcome these, because I think if you can't say no, your yes is meaningless, as Peter Block says. So it's important to bring dissent and to bring the doubt. Let's have them. Let's have them out and talk about them. So just the other one is, well, are communities always best placed? Do they always know best? So let me start with the do communities always know best? I would say, a bit like families. If you've ever had an Irish Christmas dinner, you realize all families have baggage, and you're probably crossing your fingers to not be set beside certain people and so forth. So I think community, a bit like I'm sure your institutions, are full of all kinds of spicy parts, as well as the very nice woolly novel lovely parts. So we're not talking about communities as if everybody is holding hands and singing Kumbaya as they walk into the sunset. Let's be very clear about this. There are lots of really, really difficult issues, and that's important to acknowledge. I gave an example in the chat in response to this of saying, in our work in Kibera in Nairobi, and I don't want to get into the actual specifics because it's so distressing to even think about it, but there were certain sexual health beliefs and myths among men in Kibera, which no ethical practitioner getting alongside that community would endorse or would say, well, they know best, it's what they believe, let them at it. But I knew as an outsider coming into that community, which, you know, is considered to be a slum and fluctuates in population between 600 and 900,000, depending on the floods in the rural areas of Kenya. The idea that a public health or any practitioner would go in and would talk sense to these young men about what they were doing, just nonsense. But, and this is the point I think that's key to make here, if you understand how to work with that community as an organism rather than just 600,000 disaggregated people, and you understand how to work in a community animating way, well, it's pretty clear in your mind that the first thing you want to do is build trusting relationships with the connectors, because it's the connectors that live in that community that convene and influence how people think and who challenge myths. But also in that community, every single person was very keen and very motivated to be part of a burial society, because the last thing they wanted was to die and not have a dignified funeral. And it was actually the people in the burial societies that did more to change the behaviors of young men around sexual health in that community than any hospital or public health person. Bless them, they're wonderful, they're hugely important. But here's the dilemma. So we have, and I have it too, this great impulse as a professional, as a practitioner, to get my expertise used. Why wouldn't I? Everybody is the same. The difficulty is you're not going to get your expertise used in communities unless they trust you. They don't care what you know until they know that you care. That's simple. So a lot of the time, hospitals are trying to solve relational issues with technical solutions. It's the wrong tool for the job. It's like trying to eat soup with a chainsaw. It's messy and it never works. So let's try other tools. There are two tools for health. One is community. The other is the institution. What we have at the moment is a massive focus, and we're foregrounding the work of the institution and often the bureaucracy of that institution, not necessarily the health creation. And that I see as this other point was this frustration that people are having at the moment, recruiting staff, retaining staff, 2.2 million people in Ontario not being able to get access to GPs. These are real issues. And I want people listening to know we take these serious as a panel. But decisions are going to be made by politicians and bureaucrats in each of the 10 provinces. Do we spend more money on building more hospitals? For 2 hospitals in the province of Ontario, for example, I think we could have Burt's-Org models, community development practitioners and primary healthcare teams working in probably every neighborhood. So choices need to be made. And these choices are as much political and civic choices as they are professional ones. And I think I just wanted to acknowledge that's the bigger picture here, but the panel, I think, are very acutely aware of that. So we're not talking in Pollyanna terms. We understand the difficulties.
Thank you, Cormac, for making this real, right? This is our context. It's complex, it's messy. We have a history of trying to eat soup with chainsaws. The problems are big, and we're not talking about, picking up on little pieces and, like you said, holding hands and singing Kumbaya into the sunset. We're talking about addressing the real issues, but using strategies that really work. And again, starting from this place where, they don't care what you know until you know that they know that you care. And if that's the starting point, right? And connecting that to trust, and then connecting that to right fittedness and moving that along the system, I think that we will be oriented in the right direction. But I think what I took away from that message is that, there isn't anything in our way, right? It doesn't matter what the bureaucrats are focusing on. It doesn't matter where the dollars are flowing. These things all help over time, and getting alignment with those things helps. But we're not powerless, that we have agency, and we have a lot of tools that we can put to use right here, right now to move us forward, even against these big and ugly and complex challenges. Now, I have the very unpopular job of needing to start to wind down this conversation. It's been a pleasure. And it's not going to be a cut. We're not cutting everybody off cold turkey here. We'll gradually back out of this, hopefully in a way that feels very, very gentle and very satisfying. But the way we're going to do that is by inviting each of our guests to share a final reflection, a thought, a key takeaway, something that they want to impart to this audience that they feel was an important piece to lift up from this conversation, or perhaps something they didn't have an opportunity to share and would like to offer into this space. And so I don't have a particular order, but I'm just going on my screen. I have Helen and then Lena and then Donna and then Richard and then Cormac. And then we'll go into just a few final administrative pieces. So Helen, over to you first.
Thanks, Andrea. Yeah, so much good conversation today, and different thoughts coming through in the chat as well as on the panel here. You know, building those relationships, that is where it starts. It's ongoing work. It's not a one-time time go at it. Different people will come into the room as you're building it, but it really is what keeps moving the work forward, keeps the trust in place so that people's health and well-being can be amplified and grown. And it's just so exciting to see the similarities between the work coming from the health side of things and from our community development kind of work there, to see the results that are happening for people in their communities. I think that would be it for me.
Beautiful. Well said. Thank you, Helen. Now you've all moved around on my screen because Helen came up front. So I'm sorry if I'm putting somebody new on the spot that wasn't expecting, but Lena, can I come to you?
Yeah, so thanks. So I guess my takeaway from all of this is that really the power of connectiveness and partnership, as Helen just mentioned, and that the collective impact of one community and healthcare works together can be amazing. And what works in one community may not work in another community. So we really need to keep in mind the specific needs of a community and adapt to meet their specific needs. So we really need to be community centric when we're looking at improving things for people.
Love it. What works for one doesn't work for all. We're operating at a unit of one. Each community is its own. It's its own place and space. Thank you. Donna.
Yeah, I guess my final words would be, I think we're heading in the right direction. I've been working in healthcare for a long time, and for a long time, healthcare has really been focused on that acute care entity. And it's only been in recent years that we've really seen a shift coming out to more community-based services. And I feel like what we're doing here in the Cowichan Health and Care Plan, and what we're hearing from Helen and Richard, is that we're moving further out into that community base and really taking into consideration the whole picture of what we can do in an area if we pull together. And I think that we've seen the impact here, and it's really, really exciting. And I hope that we can just continue on this path and see where we can go with it. So thank you for bringing us here today and being able to share with the team.
Thank you. It is really exciting, and I really appreciate the inspiration that you've brought forward for so many people through your work, and congratulations on your journey. Because it's not a success. It's a journey. It's a path. It's ongoing, and so just big congratulations to you, Richard. Love to hear your final reflections.
Sure, I'm a bit conflicted about what I wanted to say, but I think one area we didn't touch on, but which is really reassuring, is the whole assets part of asset-based community development. And what we've learned through some research in Alberta is that the single biggest determinant of hospitalization in the elderly in Alberta was loneliness and social isolation. So how do we deal with that? We don't need an institution to deal with that. We've got plenty of asset in the community. The other thing is, if we look at family caregivers, the single biggest care workforce, 2/3 of care is provided by family caregivers. So just to finish off by a couple quotations, which I wish I had thought of, but which I didn't, was that first of all, a health system is just people looking after people, and as they say in Costa Rica, health is a form of well-being created by community.
Those are yummy. I hope somebody put them in the chat so that we can continue to share them as beautifully as you did. Thank you, Richard. And Cormac, your final thoughts and takeaways?
Thanks, Andrea. I think one of the things that's probably useful to say as we draw to a close is that health, and we know this, health isn't something we deliver. It's not a program. It's not a service. It's something that all of us discover, and we can't do it on our own. You don't dig inside your body and find this thing called health. It's communal. It's collective. So it makes no sense to think about health as a unit of one, an isolated individual. The basic unit of health is the community. And I think it's an act of both good insight and modesty for the institution to think of itself as supplementing the community health creation. So this is a kind of key piece that I think is the cap on all of this conversation, saying we can have a new triage system that says, you know, when we think about health, our first question is, what is it the community can do that is health creating? What are they currently doing that is health creating? How can we cheer them on? And what else would they love to do that they care about? And how can we remove the barriers and authenticate them, legitimize them, and say what you're doing matters, it's health creating. And then I think it becomes much easier to figure out what are the things that the community want to do with us, where we can fit in and we can be useful and almost just be a supplementary support. I think this is key. Health care is not the food, it's the vitamins. We're confusing it. Community is the food that nourishes health creation. Health care patches us up. And we really need to get that clear in our heads. That needs to be a very fundamental learning in everybody's early, education and right through to medical education. The final piece, though, is really important. We're not setting up this kind of binary narrative where we're saying community can do everything, institutions are bad. That would be overly simplistic and simply wrong and unhelpful. What we're actually saying is there's certain things communities can do themselves if we do the community development to animate and support them. There's certain things they need a little bit of help with, but that help needs to be in service of them, not in some kind of a formal service to them or for them. And finally, communities still need healthcare. They still need things to be done for them, but we can't know what communities need done for them until we know what communities have. And this is the key piece. So just a final observation, I guess. I think an awful lot of people on this call may be people who are sort of in the gap, in the borderland between what we're describing as the great potential that communities have if they're organized and connected to be health creators. And I'm not talking about replacing hospitals with community, let's be clear. There are limits to local, but insofar as they can. And that's not just about services, that's about living life, that's about addressing loneliness, it's about, the good life, that kind of stuff. So I would also say there are things that communities can do with a little bit of help. And this is where people like Lena and Donna and Helen and Richard have been really important in my mind, because what they do is they protect the gap between communities that are kind of trying to figure out what is it we can do in a world that basically professionalizes everything in health, really. It's a massive hegemony saying, I'm just an ordinary layperson, I can be a health creator. Well, they're in the gap, encouraging people, and I would say also pushing back, and particularly Richard does this, pushing back against the hegemony of the healthcare system and the bureaucracy and saying, hey, folks, back up. You're engaging in overreach here and you're doing harm to the health creating capacities of communities. Many people who are listening here may be feeling caught in the gap. And I just say, friends, take courage. The work you're doing is really important. It's legitimate. And if you don't do it, it will not get done. I know it's frustrating. You have a master speaking in both ears, the community in one, the institution in the other, but keep minding the gap, because that's the work. That's what we get paid to do. And it's honorable work. So onwards, and thank you.
Thank you. And it was an honorable contribution from every panel member today. We are grateful to each of you for your contributions and for holding space in such a beautiful way. What I saw happen in the chat was absolutely evidence of community, right? We brought together a community in such a meaningful way today. HEC is really, really pleased to be able to be a supporter of this community and to be an organization that holds space and provides support where it's needed in order for you people to do the work in your communities that is so important. So thank you for the invitation and the opportunity to host this on your behalf today. I'm going to put up into the on the screen here now a feedback poll. If you could just take 30 seconds, we would really appreciate knowing the impact of this event through those poll questions. We hope that it's been an absolutely engaging session for you. It has certainly been for us. We welcome your comments in the chat also. If there's something that really struck you, spoke to you, that you want to lift up, that we can take a moment to enjoy after this event, we'd love to hear really what mattered to you in this conversation, and how might you do something with that. But finally, I'd just like to thank Cormac and Richard, Donna, Lena, Helen, for all your reflections and your wisdom today. And also thank you, our audience. Thanks for joining and making this a really engaging and interactive discussion. Enjoyed this thoroughly, and I look forward to connecting again. So stay well, everyone. Take care.